If you've got an ankle that looks like this on the AP view, or this on the lateral view, you've got some work to do. Let's turn to my friend Nick Reiners with orthopedic surgery, who's helped a lot of us in the emergency department.
Hi, I'm Nick Reiners. I'm one of the orthopedic surgery residents at the university, and I'm going to be talking about how to reduce and splint a typical ankle fracture in the emergency department. And so just to get started, I've written down to some supplies that you should have in mind, because getting everything set and prepared will set you up for success. So I believe the majority of ankle fracture dislocations can be done without the need for procedural sedation if you do a good hematoma block. So for those supplies, you'll need some sort of a cleaning solution, 8 to 10 cc's of 1% lidocaine, that can be without epinephrine, and then 18 gauge needle to draw it up and 20 gauge needle to inject. Then if you're dealing with an open fracture, you'll probably already have orthopedics contacted, but some supplies that I would use is betadine soaked 4x4 gauze and ABD pads to put directly on the skin after washing it out. And then for the actual short leg splint, I would have 3 to 4 inch web roll, plaster, and then ACE wrap available as well. One of the most common mistakes, or not mistakes, but things I see is providers using web roll and ACE wrap that is too big. And I think that big supplies just bunch up easier and it's tougher to manage. And so if you keep it smaller, then you will reduce the bunching that you get with web roll, as well as prevent the plaster from actually becoming circumferential around the ankle itself, which we can talk about later as well. So the actual fracture that we're going to be doing is kind of the most typical ankle fracture dislocation that we see. These are also called trimal fractures, meaning that there's 3 bones involved. So this is the normal anatomy of the tibia, fibula, and talus. And if it breaks, it most often breaks and dislocates in a posterior and lateral position. And in orthopedics, when we talk about dislocations, we always refer to the most distal bone for that position. So in this case, the talus would be dislocated laterally and posteriorly if this is the lateral view of the tibia and the talus. So our goal as emergency medicine doctors and orthopedic surgeons is very simply to get the talus back under the tibia. So that's what we're going to be talking about today. So we're going to start out talking about the hematoma block. So we've talked about the supplies up top. I'm going to assume that I've already done an exam and a neurovascular exam on this patient. And then what I'm going to do is essentially feel for a landmark, which is going to help me with my injection site. I'm going to feel for the tibialis anterior tendon, which is a big tendon right in the front of the foot. You can highlight it by having the patient try to dorsiflex their foot. And you see it's this big tendon mass here. Now they won't be able to do this with an ankle fracture, but you'll still be able to feel this big tendon here. So your landmark is going to be just medial or on the inside of that tibialis anterior tendon, because on the lateral side you have the dorsalis pedis artery. So as long as you're medial, you're safe. So what I would do is I would feel for that tendon, and then you're thinking of going straight down into the tibiotalar or the ankle joint. So I would mark a spot. Should be a soft spot right there. I would mark a spot with my pen. And then after I've cleansed the skin, and I have my 8 to 10 cc's of lidocaine and my 20 gauge needle, then I would simply go right in on that spot and right down towards the ankle joint. I would cheat a little bit medial, again, because you're safe medially. And then I would aspirate a little bit, and I should get some blood because I'm getting into the fracture hematoma. As long as I have that, then I just plunge and put the rest of the numbing anesthetic in there. And for it to really work, you want to wait 10 to 15 minutes. And so I would recommend doing this even before you grab all of your splinting supplies, because that will save you time. So the next step will be to simply measure out our supplies. So I've already noted that you want to grab smaller supplies than you think you'll need to help prevent it from bunching up and so that you don't create a circumferential plaster cast. So the first thing I would have the patient do is they'll be laying down in bed. So I'll have you lay down, Nick. And then to measure out the plaster, what I like to use is you can use medical tape, or you can use the plaster itself. And your landmarks for both of your plaster splints are going to be just below the popliteal fossa for your posterior slab, extending all the way around the ankle to the metatarsal heads so that the toes are free, and that would be your posterior slab. And then your stirrup, or your U, will go around the midfoot and then wrap up below the proximal fibula, okay? The goal after you're done with the splint is for the patient to be able to fully flex their knee and to move all of their toes. So to measure out your plaster slabs, you can either use the plaster itself, which is totally fine, but it's a little messy. Otherwise, you can use some medical tape, which sticks really nicely on the patient and shouldn't bug them as much. And now I'm measuring out the U. Again, the proximal fibula is going to be our landmark for the U. And then you just tear it or cut it. And that, now you have your U that you're going to measure out. And you can put that aside. And then again, you do the same thing for the posterior slab. So distally, you do it on the metatarsal heads, wrap it around the ankle, and then proximally it's at the level just below the popliteal fossa. And again. One of the most common things that I see is that the U, or the stirrup, is too far back, meaning it gets put along the heel, and that's a problem because it doesn't help dorsiflex the ankle. Alternatively, you can open your plaster, like I said, and just measure it with the plaster itself. It's always better to err on a little bit of the longer side because the plaster will shrink when it's hot, and you can always just fold over a little bit extra versus being short. So then, now that I've measured this out, I'll open my plaster. And he has a smaller leg again, so I would not use anything more than a 3 or 4 inch plaster here. And you have your tape measured out for your splint. Make a small tear in your plaster. And here's the length of your, this will be your stirrup or your U. Now to save time, you can open up another pack. Put something on the floor so that your emergency department techs don't have to clean up after you.
Team player.
And then you already know the length or your template of your first one. So if you have a second one, you can just let that drop to the ground. And then you're simply going to that cut you made and folding it over. So now I know I'm 4 thick. And you're going for 8 to 10 thickness. So this is your U, or your stirrup. Set that aside. Now you do the same exact thing with your plaster, which can be the same size for your posterior slab. So again, I measured out with this tape what it would be. Put that on the table. Measure it out. Make a rip where it's going to be. And then I know the length of this one based on the rip I made. So that's 4, 6, 8. And I'll do 8. Rip up. Okay. So now hopefully our hematoma block has worked, so we can actually do part of our reduction. So the first thing I would do is, with the patient laying supine, I would again look at my x-rays or pull them up and make sure we're dealing with a posterior lateral dislocation. With one hand, I would reach and grab the tibia or the leg like this. With my other hand, I would grab underneath the heel and think about where this talus is dislocated. Again, it's posterior and it's lateral. So in order to reduce it, I'm actually pulling some traction with my right hand, that's unlocking it, and then I'm dorsiflexing the foot to get it from being in that posterior position, and I'm pushing medial, or I'm pushing this way, and that should actually reduce the ankle. That's if you're doing a manual reduction. The alternative is you can try a Quigley maneuver, which sometimes does the reduction for you. And a Quigley maneuver is simply grabbing underneath the knee and flexing the knee so that it relaxes the gastroc, grabbing the big toe of the patient, and then lifting it up in the air and having them drop their leg into your hands and totally relax. Now, if you see what that's doing is with my left hand, I'm actually pulling the foot medial, which will reduce my talus, as well as dorsiflexing the ankle. So sometimes what I'll try first, without even trying to manually reduce it is I'll just do a quiggly, pull the toe up a little bit, and then you'll hear a clunk, a very satisfying clunk.
Because these are very unstable
They're
injuries.
extremely unstable, yep. So now we're going to assume that we heard that satisfying clunk, whether we did it manually or whether I did the quiggly maneuver. So the nice thing about the quiggly maneuver is it holds the ankle in a reduced position for you to splint. But you will need an assistant. So I'll ask my assistant here to grab one under the knee and the other finger grab on the big toe. And again, if you look at this position, the ankle is slightly dorsiflexed. The foot is supinated or inverted, which helps medialize the talus. And this all helps hold the reduction in place. So now I'll kind of start applying my web roll. Again, we'll think about our landmarks. We don't want the splint to go beyond the metatarsal heads or up past the popliteal fossa. So the first thing I'll do with my web roll, again, when applying web roll, the trick is to have the roll facing you versus like this, because then you're not fighting your own roll. And again, the more you stretch it out, the more unwieldy it'll be. So I like to keep it wrapped pretty short and tight to the skin, which will prevent bunching. So my first roll around the metatarsal head, since these are a bony prominence, is to actually wrap it 3 times or 4 times around to provide a nice cushion for those metatarsal heads. Now I'm going to forget about the ankle for a second, and you'll see why. And then I'm working my way along the leg. Again, I'm keeping it really close to the body because that's making it so it's not bunching up. I'm overlapping by about 50% so that you can't see his skin. And again, web roll will tear if you're stretching it too much, and so the natural thing is just to keep rolling it as you're able. And then I'm going up just below the popliteal fossa at about the level of the proximal fibula. And again, up here at this kind of bony prominence, I'm wrapping it about 3 times around here to provide good support. And then I might come back down one more time. You can tear it if you feel like you're not in a good position, just so I can't see any of his skin, because the splint material will be really rough on the skin. So now you'll notice I left the heel alone instead of wrapping it all in one, because this is an area that gets really bunched up. So what I would do now, or even have this done earlier, is I would create kind of three ply thickness web roll straps as such. And then I would use this to essentially kind of basket weave the heel, provide some padding. If you grab around that stirrup and grab back here with the finger and pull, it'll get rid of that excess. So that one went like a U, and then the other one can go kind of like a posterior slab as such. And again, web roll tear is really easy. So if you support it in one direction, you can tear it pretty easily in the other direction, so it doesn't bunch up. And then just to make sure it doesn't fall, you could reinforce it one time. And another time. You want to make sure you don't get too much padding at the dorsum of the ankle, because that can bunch up and cause a nerve injury or a nerve irritation. So now the heel is properly padded and all the skin is covered, now we can get our plaster wet. So we're getting ready to put on our plaster. Again, we have our stirrup or our U and our posterior slab. You can start with either. I would recommend starting with the U or the stirrup, and I'll show you why in a second. So I have our warm water here. I'm going to use kind of a slinky technique to get this wet, going back and forth to get it down into the water. And then as I lift it out, I'll keep it above the water. With one hand, I'll hold it top. With the other hand, I'll use my 2 fingers to smooth out any of the bumps, and this also gets some of the excess water out. The more dry you make it, the faster it will dry. And so if you're working to get your mold, you might want to make it less dry to start. And again, this is going to be our stirrup. So I'm going to go around the mid-foot, as I said earlier, up until the level of the proximal fibula. You can see here I had plenty of excess, so I'm just going to fold it over a little bit. And that's kind of what that looks like. Now, part of the reason why I did that part first is because notice I don't have to have an assistant also try to hold the splint material up, because I put it around the midfoot and I've cheated it slightly anteriorly so that we're not fighting against gravity. And again, notice I've picked a smaller plaster size, which still leaves minimal opening in the front. So imagine I used like a 6-inch plaster here. You could see how it could very quickly become a circumferential plaster cast. So next is the posterior slab. I'll do it in a similar way. Again, kind of a slinking technique. Get it into the water. Again, depending on how fast I'm trying to work, I would either try to dry it or leave it more wet. And this one is going to be our posterior slab. So the metatarsal heads is what we're aiming for, wrapping underneath. And again, trying not to go beyond the popliteal fossa. Now I will have my assistant help just try to hold that in place while I grab a roll of web roll and reinforce it. Now this rolling doesn't have to be pretty, because in this sense, you're just trying to cover up the plaster from getting onto the ace wrap. So I'll just try to wrap this as quick as possible so that I can get my ace wrap. Again, I've chosen 4-inch here. I think that's a good size. It's not super unwieldy. And I'll apply this. It's nice if you have a double 4-inch ace wrap, because that should be able to get it all in one. But usually you need 2. All right, now it's time to do our mold. So when molding, think about where your bones are or wanted to go, meaning where did they fracture, where were they headed? And most of the time it was posterior lateral. So now I can ask my assistant to essentially give me the ankle, and I have it. With one hand, I will, using my palm, place it at about above the medial malleolus, or the inside of the tibia. With my other hand, I'll go with the palm just kind of below the distal fibula, or where I think the distal fibula is. And then I'm using my chest, as you can see, to kind of hold this in a dorsiflex position. And finally, if there's a big posterior malcomponent that you're trying to prevent the talus from dropping posteriorly, I use my fingers of my right hand to pull up in a posterior to anterior direction, along with pushing in so that so that the talus doesn't slip posterior or in the back. And then it's flat palms, it's pressure, and it's using your pecs or it's using your chest to hold that reduction, okay? So it looks something like this. Patients will not like this. They will likely moan or scream out in pain, and that's how you know you're probably doing something right, is because you're trying to hold that all 3 bones in the right position. So again, point 1 is above the medial malleolus, point 2, and you can help patients out by kind of pushing into their body here. Point 2 with your palm is distal fibula, and point 3 are my fingers pulling up on the talus. Okay, 1, 2, 3, and then using your chest to dorsiflex the ankle. So you hold this until the plaster gets sufficiently hard, and you'll notice that when you're done, the splint is kind of in a banana shape almost. It's not it doesn't look perfectly linear, which is actually a good thing. We always say that crooked splints make straight bones. The final thing you can do to make it look pretty is just tuck under your excess ace wrap and web roll, both up top and down here if you like. Then you can see that the patient is able to wiggle all of his toes and then also fully flex his knee. And you're not putting pressure on the proximal fibula, which is where the common cranial nerve wraps around.
And they should be able to feel all their toes and no
Correct.
numbness.
Correct. Yeah, you do a brief neurological exam, make sure they can still feel the spots that you can visualize. So deep perineal nerve, superficial perineal nerve up here, saphenous and sural and tibial. And then make sure they can wiggle all their toes and that they have good capillary flow, which he does.
That looks like a work of art. So Nick, one thing I notice in a lot of my reductions is that the talus ends up still being a little bit posterior dislocated after my reduction. Can you comment on how to best prevent that from happening?
Yeah, so if you see on the lateral x-ray that there's a big posterior malleolus fragment, then you have to be wary about putting the ankle in too much dorsiflexion, because that can destabilize the fragment and keep that talus from ever coming anterior. So one thing I might do in that situation is, instead of putting the ankle up on my chest to help dorsiflex the ankle, I might actually just have their foot off the bed a bit, and I would sit down in a chair or something, and I would just do my mold off the side of the bed and let the foot fall into a bit of actual plantar flexion, which is usually not a great thing for reducing ankle fractures, but in this case it would be okay, and it would actually help your reduction. So that's something that I would do.
Okay, thank you.
Yeah.